Hi, everyone. Welcome. Um, my name is Dr. Vivian Miller. I am a radiologist with Radiology and Imaging, and we provide imaging services for Baystate Health in the community. I personally have been doing this for more than 25 years. And tonight I'm going to share with you some of my knowledge about screening for breast cancer. The whys, the hows, and what does it mean to have dense breast tissue? Extremely important is that if you take nothing else from this talk, remember that screening mammography saves lives. Get screened. Since mammography started in the 1980s as a broad service, the mortality, meaning people who have died from breast cancer, has decreased up to 40%. That is a tremendous number, a tremendous accomplishment that we are all very proud of. And I'm going to show you some of the ins and outs of screening mammography and how it can help you stay healthy. All right. Tonight, we're going to go over a couple of things under the breast cancer screening umbrella. Why do we screen? And what does it mean to screen for breast cancer? Some of the factors affecting our recommendations for screening are breast cancer risk. And there are multiple factors that contribute to a person's breast cancer risk, including breast density. And we'll talk about that later in the talk, specifically breast density. How do we screen for breast cancer? With imaging, the gold standard is mammography. And we'll talk specifically about how what mammograms are and how they are obtained and what findings may mean. And there is supplemental imaging screening with either ultrasound or MRI. And specifically under the topic of breast density, what does it mean? Why are patients notified of the breast density? And I'm sure everyone who's out there in the audience who has had a mammogram has gotten notification. And we're going to talk about why that happens and what does it mean. All right, so what does screening mean? It's basically taking an asymptomatic population looking for occult disease. So in our case, we're looking for breast cancer. We want to, again, which leads into the why. Why do we do this? We want to detect breast cancer at an early stage when it's most treatable with curative intent. So we want to catch, we're taking a population that's asymptomatic, so no breast-related symptoms, and you're looking to catch breast cancer if it is present at a very early stage. There are categories of risk. Average risk, most of us are at average risk, but it's still pretty high. So average risk means a 12 to 13% lifetime risk, or 1 in 8 of us will develop breast cancer over our lifetime. High risk is 20% or greater in lifetime risk. And then there's everybody in the middle, which is intermediate risk, considered 15 to 20%. We are going to talk about how these risks are determined. But first, we're going to talk about screening recommendations for the average risk woman. Screening recommendations are not the same across the board. And most organizations have their own screening or variation of screening recommendations. Most organizations, medical organizations, recommend yearly screening beginning at age 40. This is the American College of Radiology, the Society of Breast Imaging, American Society of Breast Surgeons, the National Comprehensive Cancer Network, and multiple other societies, yearly beginning at age 40. Now, the U.S. Preventative Services Task Force updated their recommendations in 2024, just a few months ago, to start screening at age 40, because they had originally recommended starting at age 50, but start age 40, but they recommend screening every other year. This is not necessarily bad, but I put this little meh here because the best way to save the most lives is to begin at age 40. All right. So what's a mammogram? A mammogram is a very low dose X-ray of the breast. And I've given you a couple of little statistics here. The average dose for 4 views, which is the standard views, is 0.4 millisieverts. This is a measure of radiation dose. 0.4. People in the United States are usually exposed to 3 millisieverts per year of radiation from natural surroundings. So it's very low dose. Anyone who's had a mammogram knows that it requires compression. Why do we do this? Not to be mean, but compression prevents motion, which gives you a better image quality. It separates overlapping tissue, so you can see any potential abnormalities within the dense tissue, and also it decreases your radiation dose. Mammography images are interpreted by a board-certified radiologist like myself. Radiologists are physicians specializing in imaging of the body. Also, mammography by law, when you have a mammogram, you will be informed in layman's terms by mail with a written result of what your mammogram showed. As I was saying down here, it's a federal mandate. All states, federal mandate meaning like in the whole country now, is all states are required to report breast density in addition to just whether or not your mammogram was normal or not, or whether you need additional imaging. All right. Now, why did this come about? Because of the Mammography Quality Standards Act. This is basically a consumer protection law that was instituted in 1992. The MQSA requires the Department of Health and Human Services to develop standards that would be enforced through strict accreditation, certification, and inspection of equipment and personnel at mammography facilities. This guarantees that you are going to have the highest quality and standardized quality when you have breast imaging. And among the many requirements here under the Mammography Quality Standards Act is to notify patients directly of their results in layman's terms. So here it's a little blurry, but I've just kind of taken a screenshot of what a letter our patients will receive. Dear patient, thanks for visiting Baystate for your imaging needs. And it shows, this is what your mammogram shows. They have a paragraph here that talks about breast density, heterogeneously dense. A lot of people wonder, what does that actually mean? We go on to say that breast tissue can be either dense or not dense. Breast dense tissue is common and not abnormal. And I'm going to further emphasize this later in the talk. But basically, this is required by law to let you know what the results are, what your breast density is, and what, in a small paragraph, what this may mean. We also tell you which provider gets this report as well, and who read it. Who read it, meaning which radiologist read it. Okay. I'm not sure, again, this is kind of in my way. I don't know if I can get this bar out of here because it is kind of obscuring what I want to show you. And if I can't do it, then I guess I'm sorry about that. The topic here is breast density legislation specifically. So there is an organization that I reference several times in this talk. It's very good information. It's called densebreastinfo.org. And densebreastinfo.org provides this map. If you go there, anyone can go to their website. You can see, this is a map of the United States. In pink are the 39 states and District of Columbia that require some level of breast density notification after a mammogram. The first was Connecticut in 2009. Massachusetts, I believe, effective date 2015. So you can actually go to this website and you can see what the requirements are for informing patients of their breast density by state. So I just copy pasted here. I did a screenshot of Massachusetts. As I mentioned, federal law, so all states now, as of September 2024, are required to report on density, specifically as dense or not dense. When you go to Massachusetts, each state has specifics of what they are required to report. So everyone in the United States is dense or not dense. Massachusetts, they not only it's required to tell you whether you have dense tissue or not dense tissue. It also requires that you are informed that dense tissue is common, not abnormal, but dense tissue may increase the risk of breast cancer. And we are going to talk about that tonight. And so this is basically just an example of what is required and why you get that specific language in your breast density and your notification of your screening mammogram results. All right. Why do we report on breast density? There are several reasons, but mostly it's to increase public awareness about the implications of dense tissue on screening mammography, and also to facilitate further discussion regarding the risk analysis and the possible role of supplemental screening for breast cancer. So this is basically, if you get this notification and you say, I don't know what this means, what does it mean to have dense tissue? First, I'm going to tell you tonight, but also please ask your doc. Please ask your doc or other provider who is monitoring your overall health what this means. It's important to know that breast density is a mammographic term. It does not relate to the appearance of the breast or the feel of the breast tissue. It's a mammographic term, and it's a measure of fibroglandular tissue compared with fatty tissue in the breast. Dense breast tissue looks whiter on mammogram. Fatty tissue looks darker gray. So this is a diagram, and this is a cartoon basically of what we're seeing, and then I'm going to show you what an actual mammogram looks like. But basically, fatty tissue is here in the darker gray, and the whiter tissue are composed of the denser tissues, milk glands, ducts, fibrous tissue. Okay. We are required to report in all of our reports, we are required to have a comment about breast density. It's subjective. It's interesting to note that there's a whole range of the appearance of breast tissue, and radiologists sometimes, some of us may look at an image and say that it's heterogeneously dense. Others may say scattered, and I'm going to show you what that means. But basically, it can vary from radiologist to radiologist of the reporting of your specific breast density. What I mean by not static, it means that breast density actually can change over time. It can change as you get older. Inverse relationship, meaning the older you get in general, the less dense your breast tissue is. It's not a hard and fast rule, but in general, older women, postmenopausal women have less dense tissue than younger or premenopausal women. It can also be related to BMI. Patients with more amounts of fat in their body can have more amounts of fat in their breast. And most importantly, when you are informed that you have dense tissue, don't worry, dense tissue is normal, and it can be seen in 40 to 50% of women. This little pie chart shows you, we have 4 categories, and I'm going to show you that in a second, what it looks like, but we have 4 categories of breast density, and we have to use specific descriptors. The descriptors include extremely dense tissue, heterogeneously dense tissue, almost entirely fatty, or scattered areas of fibroglandular density in breasts. So, and this is the breakdown of percentage of people where we see these. So almost entirely fatty breasts, about 10% of us have that. Extremely dense, about 10% of us have that. 40% have heterogeneously dense tissue, and about 40% have scattered. This is what it means. These are breast density categories according to BI-RADS. So as I was saying, Now, BI-RADS means it's a categorization with specific language according to the breast imaging and reporting system, breast imaging data and reporting system. And this is, again, our Bible when we are reporting. So this is what we mean, an example of when we report that the breast density here is almost entirely fatty. We are not out there to insult you. This is what an almost entirely fatty breast tissue looks like. This is an example of what we would call scattered areas of fibroglandular tissue. This one is heterogeneously dense, and this one is extremely dense. And you can see the difference between the extremes of almost entirely fatty versus extremely dense. All right, here's my pie chart again. Why do we report on dense breasts? Two main reasons. One, having dense tissue is an independent risk factor for developing cancer. Patients with extremely dense tissue have generally a 4 to 6 times greater risk of developing cancer compared with the other extreme, which is almost entirely fatty tissue. Why does this happen? We don't know. One school of thought states that perhaps it's related to cumulative exposure to growth factors and hormones in denser tissue. Maybe it's related, maybe that could cause increased cell division in denser tissue, fibroglandular tissue. Maybe that could be related at some point in the future to developing cancer. But there's no real hard and fast proof that this occurs, but it's one explanation. The other reason we care about dense tissue is because it can have a masking effect. And what that means is breast tumors are similar X-ray density to dense tissue on mammography. So breast tumors can be obscured, making it harder to see them if you have dense tissue. Also, the sensitivity, meaning the ability of a screening mammogram to detect cancer, the sensitivity of that decreases with increasing breast density. So I will show you some examples of that. So this is an example of the masking effect. As I mentioned, breast tumors are similar X-ray density to dense tissue on mammography. Can any of you pick out the cancer here? Well, if you can't, I will show you. Here it is. This is 2 views of the right breast, and you can see this is a tumor, and it looks very, very similar in density, and very hard to pick out on this patient with heterogeneously dense tissue. All right. When we're talking about screening, it's important to understand breast cancer risk. As I mentioned earlier, average risk is 12 to 13%, or 1 in 8 women over her lifetime. High risk is 20% or greater lifetime risk. And then there's intermediate risk, which is 15 to 20%. There are many, many risk factors that contribute to your personal risk of potentially developing breast cancer. There's factors that you cannot control, and then there are factors that you can. One of the factors that you cannot control is breast density. Other factors, including the simple fact of being a female. Genetic mutations you'll hear about. Genetic mutations actually are not responsible for most cancers. Most new diagnoses of cancer occur in women who, or people who don't have a genetic mutation, but it is very important to know in some patients that if you are a genetic mutation carrier, that you are increased risk, and you would be advised to start supplemental screening earlier. We'll talk about that later. You can't control your family history. You can't control a personal history of breast cancer yourself and/or ovarian cancer. Other factors we ask you, most patients who come in and have a screening mammogram, there's a questionnaire, and we ask you age at menarche, first period, age at menopause, history of radiation, if you've had a breast biopsy before and whether or not you've had high-risk lesions identified on those. Other factors you can't control are race and ethnicity. Factors that you can control are lifestyle factors usually. It's shown that you can decrease your risk with regular exercise, not smoking, limiting alcohol consumption, try to maintain a normal BMI, breastfeeding, age at first pregnancy. These are just a smattering of the multiple factors that affect your risk. All right. Can we do better? Should we have a more tailored approach to screening based on breast cancer risk? And this is where we talk about supplemental breast cancer screening. So supplemental breast cancer screening does not mean in place of screening mammography. It means in addition to screening mammography. So to try to tailor this, you can have individual risk assessment, meaning you as an individual you get this letter and you're told you have dense tissue. Does that mean you're going to get cancer? 100% sure? Of course not. But it is a factor that can contribute to increased risk. So you can have a formal risk assessment, which means a visit or consultation with a specialist physician or a genetics provider. You can have genetic testing if appropriate. There are risk models, and we'll talk about them. One of the main ones that we use is something called the Tyrer-Cuzick model, and I will show you what that involves. And it's important to know that just the fact of having dense breast tissue as a sole risk factor, meaning you don't have any of the other factors that we were talking about before, it puts you into the intermediate risk category of 15 to 20%. It doesn't automatically bump you up into the 20% or greater high risk category. And it's also important to know in terms of supplemental screening, there's no data to support supplemental screening in women of average risk with non-dense tissue. That means that some of you may have questions. Gee, should I, in addition to mammography, should I have supplemental screening? Should everyone have supplemental screening? Is mammography enough? Is mammography not enough? If you are a person of average risk with non-dense tissue, there's no data to support supplemental screening. That's what that means. If a person is determined to have an increased individual personal risk for breast cancer, there are advanced imaging techniques that we can use for supplemental screening. One of them is digital breast tomosynthesis, also known as DBT or 3D mammography. Another technique would be whole breast ultrasound, screening breast ultrasound, as opposed to focused breast ultrasound, which we usually do for a problem or if you're called back from a screening mammogram for further evaluation of something. And then the last widely available technique is breast MRI. You may have heard of contrast-enhanced mammography and molecular breast imaging. These are more specialized and kind of beyond the scope of this particular talk, but you can also find out more about that after, if you are determined to have increased risk and talk to a breast cancer risk specialist. But we're not going to talk about contrast-enhanced mammography or molecular breast imaging for this talk. But these three major modalities, and I'll show you more about those. All right. Risk. So in terms of risk assessment models, there are many of them. Two major ones are from the National Cancer Institute and the NIH, National Institute of Health. This is you can actually go online yourself and take a look at this, bcrisktool.cancer.gov. And it's basically a questionnaire. And this is also known as the Gale model. I don't know if you guys can, it's small font, so sorry about that. But basically, they ask you, it's a risk calculator. So they ask you certain things about yourself, your medical history, your family history and that kind of thing. The NIH tool does not take breast density into account when it calculates your risk. Very commonly, the Tyrer-Cuzick model, or also known as IBIS model, International Breast Interventional Study Model, this again takes into account all these factors. This model is used. Sorry about that. I didn't realize I had this little extra thing. So when you go, let me go back for a second to the NIH one. When you do this, it will calculate your personal risk and give you this little pie chart, which is handy and sometimes interesting. I'm going to skip forward again to the IBIS or Tyrer-Cuzick model. And again, age, height, weight, these kind of things that you can't control. Then other risk factors, including breast density, are taken into account when this model calculates your personal breast cancer risk. Shows a little pie chart, and it can be helpful. This is often used when you have a consultation with a breast cancer specialist, breast cancer risk specialist. If you have an appointment with the high-risk clinic, they'll usually use this questionnaire and this model. All right. When we're talking about advanced imaging techniques, as I alluded to earlier, these are the three most widely available, and I'm going to show you examples and talk to you about the advantages and maybe perhaps disadvantages of each of these. First is DBT, or 3D mammography, which has been available since 2011, approved by the FDA. It's incorporated into most screening centers in the United States. And if you have a mammogram here with us, you will absolutely get a 3D or tomosynthesis mammography. Whole breast ultrasound and breast MRI are also advanced imaging techniques that are commonly used if appropriate. What is DBT? What does it mean? It's basically a mammogram, but instead of this is basically a little diagram here. The origin of the X-rays here, the X-ray tube in a 2D mammogram is just stationary, and this is what we call a detector. The breast tissue is here, and the image is generated by X-ray passing through the breast tissue and generating a two-dimensional image. With three-dimensional or tomosynthesis images, the X-ray tube moves in an arc over the breast, and it acquires multiple images, which are reconstructed into 3D images of the breast. And it gives us, here's an example of what we get as radiologists. This is what we're looking at, and I'm going to show you the movie in a second. But I want to emphasize that it's similar radiation dose to a 2D mammogram, very low dose. And the reason why DBT is an advantage is because it reduces false positive findings due to overlapping tissue. False positives, the term false positive means that there's a questioned abnormality that we see on your mammogram, and we ask you to come back, but ultimately that it wasn't an abnormality after all, but does require some extra imaging to prove that. So when you reduce the false positives, that means that fewer patients are called back for additional imaging. Also, there is a proven increase detection in the number of cancers by 1 to 2 additional cancers detected per 1,000 screened. So this is a real advantage here for DBT. And here's the movie. So we as radiologists, these are the images that we page through. You can see that things come in and out of focus. And that way, if there's a tumor sitting here within the dense tissue, we're more likely to find it. This is another example. So as I mentioned earlier, dense tissue can cause a masking effect. So that's because breast tumors are similar X-ray density to dense tissue on mammography. And the 3D helps bring tumors into focus. So this is a 2D, and this is the same patient. These are the 3D images that were obtained to produce the 2D image. So you can see she's very dense. Can you see the tumor here? If you're not a radiologist, you probably can't. If you are a radiologist, you might be able to pick it out, but this makes it even easier. So let me just show you. I'm going to say, keep your eyes focused on the lower part of the screen and see if anything sticks out in your view. I think there might be some nurse practitioners out in my audience, so you guys probably can find this. All right, anybody find it? There it is. So the 3D, as you can see here, as we're paging through, this is the area. You kind of have to trust me on this one, but the 3D really helped detect this tumor in this patient with dense tissue. All right, what about whole breast ultrasound screening? Ultrasound uses sound waves, no radiation involved in this. There are two main methods of acquiring images for whole breast ultrasound screening. One is handheld, and the other one is called ABUS, or automated breast ultrasound. Automated breast, so this is handheld. You have a sonographer here, literally just passing the probe over the breast tissue and acquiring static images that look something like this. This is normal. This is the ABUS machine. It's actually literally a machine with detectors. The ultrasound device is basically placed on the breast tissue as opposed to a human pulling the probe across to acquire images of the entire breast. This is automated. So, and you get images that look like this, that a radiologist using a special workstation can review and determine whether or not there could be an abnormality sitting within the dense tissue. So this is not radiation, but some of these can actually look like mammograms, depending on how they're displayed. The advantage of using whole breast ultrasound screening is it increases the cancer detection rate by 2 to 4 per 1,000 screened. And those cancers that are detected by whole breast ultrasound screening are invasive and node negative. That's actually a good thing. So we're catching these invasive tumors when they are small and node negative, meaning they haven't metastasized anywhere. This is very favorable to treatment and cure. The disadvantage of whole breast ultrasound screening is false positives, meaning, again, as I said earlier, ultrasound will detect masses or lesions that look like potential cancer, requiring a biopsy to determine what they are, but ultimately on the biopsy, they are benign. Okay, and then breast MRI. Breast MRI is the most sensitive supplemental screening technique. It increases the cancer detection rate by 15 more cancers are detected per 1,000 screened. There's some disadvantages to this. It's expensive. It requires time. Patients can have claustrophobia. This is an MR machine, and you're in this tube. Most patients do handle it. Even if you have a little claustrophobia, you can take anxiety medicines, and most people do just fine. But it is a factor. You need an injection of contrast, gadolinium, and there are false positives associated with breast MRI as well. The proven benefit is in patients who've had a greater than or equal 20% lifetime risk. So proven benefit, if you are determined to have 20% or greater lifetime risk, you will benefit from supplemental breast screening with breast MRI. There's no benefit for average risk or intermediate risk women. All right. So I'm showing you here, this is an example of a person with heterogeneously dense tissue that was normal. She had a normal mammogram, but on a screening breast MRI, this is what a tumor looks like. And without going into all the details of physics, MRI, because it requires an injection and tumors are vascular, tumors will light up and look bright on certain sequences on MRI. And this is basically an example of one that was detected with screening. All right. So this is the American College of Radiology guidelines for screening women at elevated breast cancer risk. If you are determined to have an elevated risk of breast cancer over your lifetime, these are what the American College of Radiology guidelines show under these categories. So if you are a patient, for instance, you have a known genetic mutation or are determined to have a lifetime risk greater than 20%, they recommend annual screening mammograms starting at age 30, as opposed to age 40 for average risk patients. And regarding MRI, annually meaning every year, starting at age 25 to 30. If you have a breast cancer history and dense breasts at any age, or breast cancer diagnosed at age less than 50, mammography screening is recommended annually, starting at the time of diagnosis, and MRI is recommended annually at the start. It's supplemental, not in place of mammography, but in addition to mammography, starting at time of diagnosis. There are categories of increased risk if you've had history of chest radiation therapy before the age of 30. Usually these are young women who get chest radiation because of a diagnosis of lymphoma. And here we recommend mammography screening annually starting at age 25, again, as opposed to average risk, which we recommend starting at age 40 or 8 years after therapy, whichever is later. Regarding MRI, annually starting at age 25 to 30. And then history of high-risk lesions. Basically, this is high-risk lesions. You wouldn't know you had these unless you had a biopsy, which showed atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ. You will know what I mean if you've heard of these things, usually because someone has had a biopsy showing these things. You wouldn't know if you had these unless you had a biopsy. But if you have a personal breast cancer history yourself, other than the above, and they recommend mammography annually starting at the time of diagnosis, and consider annual screening with MRI at the time of diagnosis. All right. So, take-home points. Screening mammography saves lives. Everyone should start screening at average risk, beginning at age 40 or earlier, depending on those guidelines I just talked about, if you are determined to have an increased risk. But everyone beginning at age 40, most lives saved, start at 40 and get it yearly thereafter. Every year, come for your screening mammogram. There is no upper age limit for our recommendation of screening. So a lot of the studies will have looked at women up to age 74. But that doesn't mean that if you're 75, you shouldn't have a screening mammogram. You should have a screening mammogram every year, as long as you are healthy and expected to live 10 years, another 10 years. And we are seeing a lot of very healthy women in their 80s who can benefit significantly from screening. Remember that dense breast tissue is normal. We are required by law to report on breast density and inform you of your personal breast density. And 50% of us have dense tissue. It is normal. It is not any reason to panic that you're impending cancer, but it is important to know. Why? Because dense tissue is an independent risk factor for developing breast cancer, among many risk factors. And dense breast tissue can mask or obscure breast cancers on mammography. Supplemental screening, which is in addition to mammography, may be appropriate for some women with increased lifetime risk. Again, dense breast tissue is one risk factor. And it should also be known that in and of itself, having dense tissue does not elevate your risk to the high risk category. Commonly available supplemental screening modalities are whole breast ultrasound and screening breast MRI. And there are risk assessment models that are out there and commonly used. Speak with your doctor and/or a breast cancer specialist to determine your own personal risk and to determine whether supplemental screening, in addition to screening mammography, is right for you. So I wanted to point out that in preparation for this talk, I went to a lot of excellent, very informative websites that were very helpful in explaining everything and helping me explain these things to you. I'd recommend, if you want to learn more, densebreastinfo.org, American Cancer Society. The American College of Radiology has a whole section for patients, and they will not only tell you about screening mammography, but they'll also tell you if you're going to have any kind of other imaging tests that you want to know about, related or unrelated to breast screening. You can go to the For Patients tab, and they will tell you all about it. So you're going to have an X-ray, you're going to have a CAT scan, you're going to have an MRI. What does it mean? How do you prepare for it? How is it acquired? And all that. It's very good information. Radiologyinfo.org is also a product of the American College of Radiology. This is an excellent website. Breastcancer.org, very good website. And you can also go to the NIH National Library of Medicine. There are many sources out there. These are some of the ones that are the best, in my opinion, and I would recommend you go there if you have more questions. More immediately, if you have more questions, I am happy to answer them. And any questions, comments, or any other things that you would like to say or share, I am here.
Thank you, Dr. Miller. That was a great presentation and a lot of terrific information about mammography and, of course, dense breasts. We'd like to invite the audience to type their questions into the Q&A box, and Dr. Miller will address as many questions as she can with the time allotted. And there is one question in the Q&A box, but we'll give some time for you to do that. The first question is actually, I guess, a comment about ultrasounds rather than digital mammograms. This particular person previously had a cancer in one breast, and her breasts are so dense that she's concerned about even bothering with a mammogram and going right to ultrasounds. And would you recommend not having mammograms for something like this and just having an ultrasound test?
Nope.
Okay.
As I say, ultrasound is intended to be supplemental screening. Mammography is the gold standard. The reason is, there are many reasons why it's the gold standard. But first of all, there are some cancers that can present with not just masses, but they can present with calcifications. Mammography is the best way to determine and evaluate calcifications. So not all breast cancers look the same on imaging, and the ones that present with calcifications are not going to be seen, or not going to be easily seen, certainly with screening ultrasound. Ultrasound is very good for masses. Mammography is very good for masses and calcifications. So you get a broader evaluation starting with screening mammography. If appropriate, supplemental screening with ultrasound is maybe very helpful to you. And if you're at high risk, supplemental screening with MRI may also be helpful. Some people get both, actually.
Excellent. Thank you. This next question is, this particular person got a report back that she did have dense breasts and that they were too dense for a reading. And she's concerned about it being reported to her PCP, and should she be concerned? And they're also taking estrogen.
There's no breast tissue that's too dense for a reading. I'm not sure what that means, but there there is extremely dense tissue, as I was showing you, and extremely dense tissue can, in particular, extremely dense can mask underlying breast tumors that have the same density as normal tissue. Extremely dense tissue, I think what you may be getting at is that in an extremely dense tissue, you may benefit from supplemental screening. So again, as I was saying, ultrasound as a supplemental way of screening can detect several additional cancers per 1,000 people screened. So it's important to get your mammogram no matter what, even if you're told that you have extremely dense tissue, which does make it more difficult to detect tumors. And ultrasound can add additional information. So you should always get both, is I guess that's the first thing I want to emphasize. Don't forego a screening mammogram in lieu of an ultrasound, but get both, because again, cancers can manifest as different, they can have different appearances on the two modalities. And it's basically just getting extra information that can help detect cancer in you, especially if you have extremely dense tissue.
Oh, that's a great recommendation. Thank you. The next question, how much does HRT increase the risk of breast cancer, and at what age should it be stopped?
I don't have the specific numbers for you. That is a good question for a breast specialist.
Actually, that's okay. We do have a breast specialist, a medical oncologist speaking next week.
Fantastic.
And yeah, so that would be a question for our talk. Oh, not next week. I'm sorry, October 30th. Please
tune in for sure.
Yeah, please tune in. Thank you. The next question, how can I get an MRI? I had a mammogram and an ultrasound, but what if I want all the tests to be safe?
I would recommend talking to a breast specialist. There is a high-risk clinic actually at Baystate, and you can get a referral, have your doctor refer you to the high-risk clinic, and you can have a risk assessment. They can use these risk models that I was telling you about. And if you fall into the category based on a number of factors, again, they ask you a bunch of things. Dense tissue is one risk factor, but they'll also ask you about personal history of cancer, family history of cancer, breast and ovarian, and all the other factors like I was showing you. Do you have a history of chest radiation? Do you have other things that would increase your lifetime risk? It's really important to know your risk, especially if you want to be have the most information. You may go and they can determine using these risk models that you're actually not that high risk. You might just be average risk, in which case you could have an MRI, but unfortunately the insurance companies will not pay for them, and they are very expensive tests. They are not perfect tests either. They can also have false positives, meaning you could have a finding that looks like a cancer and requiring a biopsy that ultimately is not cancer. But the first step, I think, for you to answer this question would be to talk to a breast specialist and have them put your information into one of these risk models. And if you are 20% or greater lifetime risk, you would qualify to have a screening breast MRI in addition to screening mammography. And insurance companies should pay for that. You should always make sure. I wouldn't want to commit you to a very expensive test that your insurance company would ultimately say no. But you have to have pre-approval anyway. They won't just do an MRI without getting pre-approval because they don't want to stick people with giant bills if they don't have to.
Oh, excellent. Great recommendation. The next question, would you recommend doing your MRI and mammo 6 months apart as a screening when you are recommended to do both?
You can, or you can do them one after the other. Either way is fine.
This next question, this person has a family history, several generations of breast cancer, And should they pursue supplemental screening with their doctor, they are heterogeneous dense breast. Heterogeneous dense breast.
Heterogeneous events, yeah.
Yes, did I say that?
Yeah. You should, yes, pursue it based on maybe you want to, some providers, primary care docs are not too comfortable or experienced with breast cancer risk, in which case they would refer you to high-risk clinic. You can have a consultation with one of our breast specialists, and they can determine your risk for you. And then based on that, they can determine whether or not you should pursue supplemental screening. So I would recommend if your primary care physician or provider doesn't feel comfortable with making these recommendations, that you ask them, and I'm sure they will be happy to refer you to one of the breast cancer specialists.
Very good. This next question is about moving from Massachusetts to Connecticut. Have you heard of any problems getting ultrasounds from one state to another?
Nope. No
Okay.
problem. Especially, well, it sounds like what you're talking about is you had, let's see, if you have a palpable mass or another breast-related problem or symptom, you will never have be obstructed from getting a ultrasound. And the same goes true really for screening. Connecticut actually was the first state to implement the requirement to inform patients of their breast density with the purposes of facilitating supplemental screening to detect more cancers.
That's right.
Did I answer your question?
Yes.
Bottom line, you should not have a problem getting an ultrasound, either diagnostic or screening in either state.
Very good. Does previous breast biopsies increase risk of cancer, even if they were cysts or lymphomas? Lipomas, excuse me.
No, no increased risk just by having a biopsy.
This next person has heterogeneous dense tissue and they're unaware of their family history. They didn't nurse and they are very young. Should they have supplemental screening? It's they say supplemental screening is not necessary. Would you concur with that?
I mean, that's not a quick answer. But I would say if you want to pursue a formal risk assessment, ask your primary providers to refer you to the breast specialists, and they can make recommendations based on these formal risk models. And I would recommend you do that for sure.
Very good. Thank you. Do fibroademas require mammography screening prior to age 40, or is the best recommendation to have a breast ultrasound if you're under 40, age 40?
Fibroadenomas require mammography screening prior to age 40. No, fibroadenomas are benign tumors. If you are young, and we do biopsy a lot of breast masses that end up being fibroadenomas in young people under 40, and usually they present because of a palpable mass, because we don't detect them on mammo because we don't start screening until 40. So if you're 21 and you have a palpable mass and we see a solid mass on ultrasound, it's biopsied and it shows a fibroadenoma. Fibroadenomas are benign. So that in and of itself do not require you to start screening prior to age 40. If you have a palpable mass and it's solid and it's biopsied and it's cancer and you're under age 40, absolutely, you should screen before you hit 40.
Very good. Thank you. Is breast self-exam still advised?
Interestingly, not officially. The major organizations don't recommend self-exam as a general rule. That said, if you feel a lump, please have it checked out. You don't necessarily have to religiously and methodically do breast self-exams, but if you do, and or if you incidentally feel something, a lot of times people will say that I was taking a shower and I felt something. Please have it checked out. It may very well be something benign, but you don't want to ignore something that could be a potential cancer. Come get it checked out, get imaging, and let us figure out what that is.
Very good. The next question, when you have a biopsy and a clip is inserted, would you have concern for that biopsy area changing over time if it was deemed benign? The clip helps to identify the area, but how can you know the tissue does not change?
Benign biopsy, it depends. Well, there's a spectrum of benign, but let me just say, first of all, when you have a biopsy, we always call you personally with the result. If the there are biopsies that turn out to be benign, but they're high risk lesions like those LCIS and AD atypical, etc. Those are benign, but they still require surgery. To specifically answer your question, if you get a standard benign biopsy, benign breast tissue or fibroadenoma, like we said, or some other benign process on a biopsy, there is no chance that that will evolve into cancer. How do you know the breast tissue doesn't change? You get your screening mammograms after. So the first thing is 6 months after a benign biopsy, if you've had one, you know what I'm talking about. 6 months after a benign biopsy, we recommend a follow-up at 6 months with imaging, either with ultrasound if the lesion was detected on ultrasound, or mammography if it was detected on mammography. And then we take a look at that area that was biopsied to make sure it doesn't change on imaging. If it doesn't, and most of them do not, we recommend that you just go back to screening. Does that answer your question? If you have a standard benign biopsy, and again, there's a spectrum of benign things that you could have, but it will not evolve into cancer. And if it is a benign diagnosis that could potentially evolve into cancer, we're going to let you know that and refer you to a surgeon to have it removed. But that's a specific case. And you would know.
Very good. Thank you. We only have time for one more question. When you have an MRI that includes the torso for other reasons, does the radiologist check to see if there is any breast cancer?
When you have an abdominal MRI, is that what the question?
An MRI that includes the torso.
Oh.
For other reasons. We're wondering if a radiologist looks for breast cancer.
Well, we evaluate the anatomy in the field of view. So if you're asking if you have an abdominal MRI that includes some of the lower breast tissue, we will look there, of course. If you're having a breast MRI that includes the abdominal tissue, we will look there too. But when you are having a dedicated breast MRI to look for cancer screening, and that does tend to include like liver and the anterior chest wall, we will comment on that. We look at all the images and all the anatomy that's included. Does that make sense? Hopefully.
No, it does. So, well, that's great. Well done, you. I applaud you for your expertise, frankly, because I could not find anything on those images you shared. So I applaud your work, and I thank you for this great presentation and the great Q&A. And thank you to our attendees for those great questions, too. Thank you, Dr. Miller. We really appreciate you.
Well, thank you for giving me the opportunity to get the word out. Thanks for everybody who's attended, and I hope you guys have a wonderful night, and we'll see ya. Maybe you'll even see me someday for screening, one way or the other. Thanks, guys.